Hello, and welcome to CDC. My name is Dr. Deborah Howry, and I serve as CDC's Chief Medical Officer and Deputy Director for Program and Science. Although I cannot be there in person with you today, I am encouraged to see how many people registered for this event from across the country to discuss how we can address dementia through a public health approach. I want to start by thanking the Alzheimer's Association for hosting today's summit. As CDC's bold Public Health Center of Excellence on Risk Reduction, their dedicated work has brought us all together today. Alzheimer's disease and related dementias are a growing and urgent public health concern, affecting more than 6 million adults in the U.S. and 1 in 3 people over the age of 85 years. The number of adults living with Alzheimer's is projected to double over the coming decades, making prevention and risk reduction even more imperative. Although dementia doesn't only affect the older population, people face more challenges with everyday living activities as they get older. These include increasing functional limitations such as vision, hearing, or mobility challenges that can result in an increased risk of disability, chronic diseases, and mental health concerns. Developing a chronic disease or disability can make it difficult for one to manage their health and also increases the risks of further developing additional chronic diseases. For example, someone with dementia may struggle with their memory or communication, which may impact whether they eat a nutritious meal or take their medications. We must address the known risk factors from a public health perspective, while also promoting healthy aging. Based on what we know, what keeps a brain healthy is similar to what keeps the heart and body healthy. While some risk factors can't be changed, evidence suggests that small lifestyle changes can benefit brain health and reduce the risk of dementia as well as other chronic diseases. Promoting healthy aging and reducing the risk of dementia is a national priority. Goal 6 of the National Plan to Address Alzheimer's Disease promotes healthy behaviors such as increasing physical activity, eating a healthy diet, quitting smoking, and reducing excessive drinking. Evidence-based interventions that promote healthy aging related to Alzheimer's disease and related dementia risk factors can make a substantial impact in promoting the health, well-being, and independence of older adults. At CDC, we are focusing on evidence-based health promotion activities across the lifespan that support longevity and improve quality of life as people age. This includes promoting physical activity and self-management education programs for diabetes and hypertension. We also support interventions that reduce barriers in accessing healthcare, particularly in communities with the greatest burden. CDC is focusing on addressing the social determinants of health that lead to health inequities, as well as population data that show higher prevalence of chronic diseases and dementia among various races, ethnicities, and groups. We're promoting activities that help foster a healthy body and healthy brain in these populations. And lastly, I want to note our commitment to strengthening our systems and processes to equitably deliver science and program activities to the American people. We are building on lessons learned during the COVID-19 pandemic and robustly addressing dynamic and unpredictable public health challenges in the future. This includes sharing science faster, prioritizing public health communications, promoting results-based partnerships, and developing a workforce prepared for any future emergency. Again, I am excited to have so many of you here today sharing a passion of helping millions of Americans understand, manage, and reduce risks for dementia that cross-cut many other factors of our lives. Together, we can work to improve quality of life and decrease unnecessary hospitalizations and deaths. I hope you all have a successful meeting and make great connections to further your work.
Please welcome to the stage the Deputy Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services, Dr. Tisa Marie Sherry.
Morning. It is, oh my gosh, I love that. I got a good morning back. So great. So great to see so many people here bright and early to begin our work together. We are so excited for this summit. I want to take this opportunity to thank our hosts and organizers for the incredible work that they did to put this event together, and also for all of you who are here and here to participate in conversations, lend your expertise, and help guide us in the work that we're doing. So let me start by sharing a little bit of kind of background. So I work in the Office of the Assistant Secretary for Planning and Evaluation at HHS, or ASPE for short. And in that office, I lead our Office of Behavioral Health, Disability, and Aging Policy. Now, ASPE, for those who don't know, sits in the Office of the Secretary at HHS. We do policy research, we analyze policies, we advise the Secretary on policy development, and also we help coordinate large cross-cutting initiatives across all of HHS to try to make sure that we are really rowing in one direction as a department to address some of our most critical priorities. And it is in the context of this work that we in ASPE have the immense privilege, it really is a privilege, of getting to oversee our work as federal partners implementing the National Alzheimer's Project Act, which, as I'm sure everybody in this room knows, was a landmark, incredibly important legislation passed in 2011, which has really altered the landscape of how we collectively address Alzheimer's disease and related dementias. Now, National Alzheimer's Project Act really charged the federal government to galvanize ourselves, focus our efforts, and grow our efforts to really comprehensively address Alzheimer's disease. And it did so in a couple of different ways. The first was that it required that we create an advisory council to review and comment on our strategy, its implementation, to make recommendations to our secretary and to Congress on how we could be better addressing this public health crisis. And that advisory council is comprised of both federal members but also non-federal partners from a wide array of perspectives and has been incredibly helpful in informing our work. It also required us to create and update on an annual basis a national plan to address Alzheimer's disease. And this plan really serves as our comprehensive strategy across the federal government to help direct our efforts. It allows us also to track our progress and to identify where there are gaps and opportunities to do more. When the plan was established in 2012, it originally had 5 goals: to prevent and effectively treat Alzheimer's disease, optimize care quality and efficiency, expand supports for people with the disease and their families, enhance public awareness, and also track progress and drive improvement. Last year, we celebrated the 10th anniversary of the National Plan. We had the opportunity to reflect on the incredible accomplishments that have occurred in just a decade. And they are really remarkable. There has been more than a 4-fold increase in federal funding for research on Alzheimer's disease and related dementias. We've been able to train thousands of healthcare providers on how to better care for people with Alzheimer's disease and also better support their families and caregivers. We've been able to support the development of dementia-capable long-term services and supports programs in 38 states, have led major public awareness campaigns, and also this plan has actually become a model for plans that a number of states have adopted. So all this progress is tremendous and wonderful, but we really need more. As Dr. Howry just mentioned, despite all of these efforts, the prevalence of Alzheimer's disease is projected to continue growing. There are estimates that by 2060, as many as 14 million people will be affected. As everybody in this room knows, that has incredible consequences, both in terms of the human toll, the toll on families, but also how it affects our healthcare system and our economy and our global competitiveness. So it really a public health and also a public policy imperative that we try to alter the trajectory here. And so, with that in mind, in December of 2021, we decided to open a new frontier in our efforts in the national plan and in the federal government to try to address Alzheimer's disease, which was by adopting Goal 6 to accelerate action to promote healthy aging and reduce risk factors for Alzheimer's disease and related dementias. Now, this goal came about because we were really excited by the growing evidence suggesting that there are certain modifiable risk factors that if we intervene upon them, we can reduce the population level risk for people developing dementia. And let's pause and think about that for a moment. I mean, how incredible, what an incredible opportunity that presents to us, that we now have that evidence to help drive and focus our efforts and open up new avenues to try to address this public health challenge. And we decided we wanted to seize this opportunity and really use every tool at our disposal to try to tackle this. We're really, really proud of this goal. It demonstrates our commitment at HHS, but also across the federal government to making progress against Alzheimer's disease. And I also want to take this opportunity to recognize and thank our Secretary Becerra, who has been a huge supporter and champion of this work through its inception. But what I also want to say, especially with all of you in the room, is that this is a collective victory and accomplishment. This goal came about because of the commitment of so many, because of the hard work of so many, both to shine light on the importance of risk factors and the opportunity to address them. And that includes our partners in the public health community, the research community, the advocacy community. And really, for all of us, this goal represents all of our collective efforts to try to open up a new frontier and to address this challenge. And we want to thank all of you for your partnership in helping to get us here. So how are we approaching Goal 6 at HHS? There are a few areas in particular that we are prioritizing in our efforts. The first is to continue generating evidence on what modifiable risk factors have the strongest association with Alzheimer's disease and related dementias, and also what interventions may be effective for trying to reduce their prevalence in the population. We're also prioritizing trying to share that information with the public, with people, with healthcare providers. Having that information out there is a key first step to enabling people to use it and to make changes. But also, as the evidence is still evolving, we want to get started right away in helping to develop and strengthen the infrastructure to translate that into effective clinical interventions, effective community-based interventions, and policy measures. So that as we get new evidence, that gap from generation to translation and adoption can be narrowed, because we don't have a lot of time here. We've really got to prioritize this. We are trying to align our efforts across all of the areas in which we work to promote healthy aging. Many of the risk factors that have been identified for Alzheimer's disease are the same ones that we try to address in order to reduce the burden of many other chronic conditions. And there are areas in which we have a tremendous amount of activity underway at HHS. So we want to try to take a look at our existing efforts and see how we can better align and synergize with those. And then finally, but perhaps most importantly, a really key driving goal for us is to leverage this goal and this opportunity to promote equity and to reduce the pervasive disparities in Alzheimer's disease and related dementias that we see at really every single stage of the care continuum. One of the things that is particularly troubling to us, as I'm sure to all of you, is that in the coming years, not only is the prevalence of Alzheimer's disease estimated to increase, but the gaps between white communities and Black and brown communities are projected to grow. The disparities are projected to widen. That's not acceptable. So to us, success on this goal is going to mean not just reducing the number of cases of Alzheimer's disease, but narrowing as well those gaps. And we feel that Goal 6 is a critical way for us to try to get there, because even at the time of diagnosis, we know that the burden of risk factors is not distributed equally. People do not have an equal chance of developing dementia. And if we're going to make progress on that, we have to start much further upstream, even before people get in the door to see their provider and get a diagnosis. These are just a few examples of some of the action steps that we're taking as part of our national plan to address risk reduction. They span research, training, disseminating and deploying effective clinical and community-based interventions, but also messaging to ensure that we're getting information out there. Now, this is all wonderful, but there's just one small challenge, and I think the people in this room understand it better than perhaps anyone, which is that so much of what we want to achieve here relies on being able to change health-related behaviors. And that's really hard, like really hard. And we know that because we have decades of experience trying to do that. One of the most challenging things that we as a public health community and health policy community have tried to do for years now is to encourage people to exercise more. Eat healthier. And we've made progress, yes, but it remains one of the most pervasively difficult things to do. And I think many of us in this room understand it because we all live it. How many of us, wish we could eat healthier, wish we could, get out and exercise more? I mean, probably every single one of us in this room. If any of you in this room don't feel that way, then I'm really, really jealous of you. I want to find you and ask what your secrets are afterwards. But, we understand this because it is really, it's a truly challenging thing to do. And when you think about it, it requires time, resources, reorganizing and reprioritizing routines to do this. That is not a straightforward thing to do. And we're often asking people to take this on and do this in an environment where they have very little support to help them do it. Take hypertension as an example, one of the modifiable risk factors with one of the strongest links to cognitive impairment and dementia. And for hypertension, we actually have medications that are pretty cheap, that are very effective. And yet it's estimated that 1 in 4 adults with hypertension has their blood pressure adequately controlled. So this is a really big challenge. Before I was in this role at HHS, I was a primary care physician. I spent a lot of time talking to my patients about nutrition, about physical activity. All were really motivated. All of them really wanted to make changes. And we spent a lot of time talking about it. But then, when I went back and reflected on what I was asking them to do, what it was really humbling to realize is that many of the changes I was recommending were things that I would have a really hard time doing myself. And that was as somebody who was very, very privileged. I only had to work one job. I had access to resources. I had access to green spaces. I had about 6 different grocery stores within walking distance of me. And I was asking, people who were not so fortunate, who did not have the benefit of all those advantages, to do things that, even with all those advantages, I was going to find a hard time doing myself. So we have to admit and acknowledge that this is challenging work. And we also have to acknowledge that the barriers that people encounter in doing this are not equal. They reflect so many social determinants of health, structural barriers to health that are very, very deeply embedded and ingrained, and also that accumulate over the course of a lifetime. So at HHS, in reflecting on this, what we've concluded is that true empowerment in risk reduction and in promoting healthy aging is not just generating the evidence. It's not just handing it to people. It's not just handing it to their providers. True empowerment means that we also lower the barriers that make it hard for people to act on that. We have to make it easier to make changes. We have to make it easier to get physical activity. We have to make it easier for people to have more nutritious diets. We have to make it easier to get more sleep. And what that requires is that we have to shift away from thinking that this is all about individual responsibility. It's all about lifestyle change, and realize this is a health systems problem, and it is a public health, and not just a public health, but a broader systems challenge. We have to remake systems, remake the environment to help people thrive and to reduce the barriers. And this is where we see tremendous opportunity. And this is where we really, really need all of you in this room, because our public health community, you are the experts in systems thinking. You are the experts in figuring out how we build those bridges between public health partners, the aging network partners, housing, transportation, all of the key players that we have to bring together to actually build more age-friendly communities and promote healthy aging. You are the ones who have innovated in systems thinking, and we need to ask you to partner with us and continue doing that. And if we are ever to have a chance to really promote equity in this space, we have to use your expertise to help us tackle the social determinants of health and structural barriers to risk reduction. Now, we have been trying to do this for a very long time. So a number of you may be asking, well, why now? What's different about this moment? And I do believe that we have a really important and unprecedented opportunity in this moment, because there is a level of attention to aging and to its impacts that we have not seen in quite some time. You know, the demographic transition is upon us. It's here. And I think this is being recognized at all levels. You can see some evidence of this in some of our recent federal actions, for example. Last year's national strategy to support caregivers, which was recognizing that with the aging of the population, we're placing more demands on our caregivers than we ever have before in an environment where they have fewer resources. You can see this in the president's executive order last month to support our caregiving economy, which also includes caregivers. Again, you know, a recognition and a charge and a set of actions to try to address the needs of an aging population. So we have attention focused on this issue. Also, we have a dynamic and changing environment at this point. You know, the COVID-19 pandemic has changed the way many people have worked. It has changed many of the spaces that we live in, that we play in. You know, there's an opportunity as we are rethinking this, as we are approaching this transition, to identify ways to guide it and direct it in a way that promotes more health, promotes healthier aging, makes it easier for people to get the things that they need to be able to lead longer and healthier lives. And it's an opportunity in a moment that, you know, we need to seize. Now, there's so much here that we could do, and it's such an ambitious chart that you might wonder, well, where do we start? And I guess that's part of what we're going to spend the next couple of days talking about. But I guess one thought I would offer is that we already have started. The work is already well underway. It's been underway for decades, you know, to try to make progress in addressing risk factors for chronic disease. But maybe this is a chance to reinvigorate, to take a look at it, to see how we can update our efforts based on the most recent science on brain health, to adapt our approaches to systems level thinking, to identify gaps, and above all, to really lead with promoting and enhancing equity. And what I want to let you know is that HHS is here to support you, here to champion those efforts. When you have successes, we want you to share them with us so that we can help you lift them up, scale them, and spread them, and so that we can be your partners to reducing any barriers that stand in your way. With that, I thank you, welcome you, and wish you all a wonderful and productive summit.
Please welcome to the stage the President and CEO of the Alzheimer's Association, Dr. Joanne Pike.
On behalf of the Alzheimer's Association and the Bold Center of Excellence on Dementia Risk Reduction, welcome and good morning. Thank you for being here today. And a big thank you to the CDC and their leadership and support on this issue. In particular, I want to call a few people out. Lisa McGuire, who heads the Alzheimer's team, Lisa Garbarino, who one of the public health advisors on the team, who is really the one who made today possible, and also Tracy Stewart, who has ensured the lights are on and the microphones are working. Thank you to all of you. Being here on the CDC campus is a physical representation of the movement we had ahead of us to translate science into action, just as the CDC does, to protect people and communities. Now, while we have to think about that and understand that there's more research that we need, we can't let perfect be the enemy of the good in terms of the knowledge that we have, that we're going to talk about today, and also the need for robust, multi-lever public health efforts. Now, bear with me, it wouldn't be the start of a conference if I didn't have a few data points to go through. And I'm not going to certainly read all of these to you, but I want to highlight a few things. Several years ago, former Surgeon General and former head of the CDC, Dr. David Satcher, called Alzheimer's the most under-recognized public health threat of the 21st century. And as you see in these data points, and even Dr. Sherry mentioned, in 2060, nearly 14 million older Americans will be living with Alzheimer's. But that projection is based on the makeup of recent and current cohorts of older Americans. And as you see in these charts, decades ago, prevalence of some of our risk factors were much lower. So as we think about obesity and diabetes as causal risk factors for Alzheimer's and dementia, and the projections of future Alzheimer's cases, we have to consider where are we at today and the growth of those risk factors and what that means for us by the middle of this next century. So while that projection of 14 million is based off of current risk factors, the future projection should be potentially much larger. And certainly something that we need to consider as we think about the dementia risk factors, just being able to influence and impact what we need to be doing in communities. And we are advancing into an era of treatment in Alzheimer's disease. While disease-modifying medications are finally here, we also have to consider what that means for our disease in the future. Other chronic diseases have had more time with disease-modifying treatments. Think about cancer and heart disease. But that has not changed the commitment to prevention and public health, and instead makes us consider how can we double down on our efforts to understand the risk factors and the combination of treatment and prevention moving forward. I want to thank you for being here. I want to thank you for your commitment to addressing the risk factors for dementia. I hope this summit gives you ideas and inspirations to act both in your work and in your communities, to consider how you choose one of these public health interventions and levers to change the crisis that we have in front of us. But before we begin the summit in earnest, I also want to introduce you to an advocate who is living with this perspective on a day-to-day basis. It is my pleasure to introduce Dan Jaworski, a member of the Alzheimer's Association Early Stage Advisory Group. Dan was diagnosed with mild cognitive impairment due to Alzheimer's disease in 2019 at the age of 54. He wants nothing more than to prevent or at least delay the day his MCI becomes dementia. And modifiable risk factors play a part in that. But I'll let Dan tell you that story. Thank you.
Good morning, everybody. While traveling with my family to Thailand in 2018, I had the unique opportunity to speak to a monk. And he had these impactful words. He said, "All life is suffering. What are you going to do about it?" Little did I know, just a short time later, these words would anchor me during a life-altering moment. Because on that very same trip, that my family gave me a heads up about something they told me. They said I was repeating myself. Where are we going? I asked. When we got home, we got home from Thailand, and I asked my wife. We were going to Rollins College. It's 2 miles from my house, a place that we've been to literally hundreds of times. And I stopped the car and I looked over and I said, "Where are we going?" And she said, "To Rollins." I said, "I know that, but how do I get there?" That was my Houston, we have a problem moment. That was the time that I recognized what they had recognized back then. Right after that, I went to the doctor and I went down a test gauntlet, and I do mean a gauntlet for you, and those of you that have gone down this path. Neuropsych tests, EEGs, cerebral spinal fluid, blood at 14 vials a time, tau to amyloid ratios, the whole thing. And after all that testing, they said to me, "I'm sorry to tell you, you've got mild cognitive impairment consistent with Alzheimer's, likely to lead to dementia." I was 54 at that moment. When I received the diagnosis, I was out for a run. I took a knee as a doctor went through it, caught my breath, and he said, "I'm sorry, you've got this disease. We can't be 100% certain without an autopsy." I said, "Doc, I'm going to take your word for it." So I caught my breath, and the first thing that came to my mind was Ironman Kona. And you're probably thinking that's a very strange thing to think about. Ironman Kona is a race you have to qualify. It's the World Championship of Triathlon. It is something I've always wanted to do. And I figured I would get the opportunity to do that when I was age 75 and all the really good triathletes were broken down and no longer doing it. I would show up, be the only one doing the race, qualifying, I'd finally get into Kona. And so that was my plan. But now that had changed. So I had to find a way to get in. And I'm so grateful. They have a thing called the Ironman Foundation. I called them up. I left about, 80 messages in mailboxes because nobody answers their phones anymore. And after a long story short, I was grateful to get in and was able to do that last October. Thank you. When I told Julie that day my diagnosis, I was home later. I said, we're going through this. And I said, I'm going to do something. I said, I'm going to get a tattoo. And it's going to say Carpe Diem, which you all know is probably Latin for seize the day. Because I figured every day is a gift and to treat it as such. And she gave me the greatest response. She said, "Can I get one too?" So thank you, Julie, out there. And we had some and then the fun kept going because my son and my daughter and really good friends of mine that I train with, they came over and showed me their Carpe Diem inked. And of course, my son's covers half his body like Adam Levine. So now the odds were stacked against me. Time wasn't a given. And at this rate, I would not get my shot at Kona. I fixed the way to get into Kona. I was determined to make the best of every single day. And I realized I couldn't choose what happened to me, but I got to choose my response. And that's really powerful for me. So I began the Mediterranean diet with no exceptions. And thankfully, red wine is on that list. I exercise 5 to 6 days a week, various distances and efforts. This is my favorite part because when I'm running and biking and swimming, I feel like I'm counterpunching against the disease. I feel really strong at that point. Sleep. Our brain's wash cycle is super important. I try to get 8 solid hours every day of that. I track it on my smartwatch. And lastly, brain engagement. For this, I took a wide approach. I use apps, games. I'm learning Spanish. I challenge my brain doing different things like brushing my teeth and eating with the opposite hand. It's very messy in our house now, but I'm getting better at it. I believe lifestyle changes buy me time, no question about it. And I have a lot of plans for what I want to do. I've got a grandson, and I got another one coming on the way. Preventing dementia must become a health priority for people like me. While training for Ironman Kona, I decided to dedicate each of my 140.6 miles to people like me that were either living the disease or had lost their life to it. I had people from all over the world: Denmark, Australia, UK, Venezuela, folks that have fought in wars, folks that escaped domestic violence, and one lady whose great-great-great-grandmother survived a concentration camp. These people cattled me to the finish line on last October on the epic course, and in the late hours of the night, I get back to my our hotel, and I raised a glass of Mediterranean wet red wine, okay, and just to celebrate their lives. And it was very impactful to me. 140 people who had the risk of this disease, and then the risk had caught up to them. Back to the monk and his words. He said, "All life is suffering. What are you going to do about it?" It's a really good question. And I thought long and hard, and I came up with 3 things. The first one is gratitude. And I say this every single day. I say, "Thank you, God, for the gift of today. I am me, and I am grateful." I believe gratitude is the second most powerful force in the world other than love, because when you're grateful, you're not scared, you're not worried, you're not alone, you're fired up. You have today, and you're hopeful you might get just a small shot at tomorrow. And that's it. I have my low beams on, and I celebrate everything, as Julie knows. So the second one is adventure. I like to have fun, and I like to talk smack, and I'm competitive with the disease. So I tell Alzheimer's, I give it the Dikembe Mutombo finger wag. For those who know basketball, he was the greatest shot blocker in the NBA, and when he swatted the ball away, he'd do this. So I tell Alzheimer's, not today. I'm still standing. I'm here. I'm not going anywhere. I understand this disease may beat me, but will never defeat me, because I will never bend my knee to a disease that does not rhyme with anything. You have the power and responsibility to move risk reduction forward. Let's make it happen. A cure would be awesome. Treatments are a start for many. Reducing risk would be a start for all. Let's make that happen. Thank you. Thank you. Thank you. I have one more thing, just because I can, because I'm up here. So I'm going back to Kona in 2040. You're all invited. I will buy you drinks and a meal at Humpy the Whale's Diner. So come with me. Thank you.
Thank you, Dan. We certainly appreciate your courage and willingness to share your story and putting a face to the need to maintain brain health. Before we can go into the focus of the next 2 days, what actions public health can undertake to improve brain health, we really can level set a little bit more on where we are in the science. What is the state of the science on dementia risk factors? What does the data tell us about the prevalence of those risk factors? And how do we use that data to drive action? So to tell us a little bit more about that, I'd like to introduce our next 2 speakers. Dr. Maria Carrillo is the Chief Science Officer of the Alzheimer's Association, and Dr. John O'Mara is the Medical Officer on the Alzheimer's disease team here at the CDC. Thank you again for all of you and your attendance today, and I will now turn the lectern over to Maria.
Good morning, and wonderful to be with all of you. What an inspirational start. I hope you're excited as I am, and Dan, you're amazing. So thank you very much for that fight and that spirit. You're just a fantastic way to get us all started. I wish I could bottle you and just distribute that everywhere. So I'm going to talk a little bit about what we think about at the Alzheimer's Association in terms of risk reduction and the state of the science. And maybe this will help us think about where we're going to go. So the review of the evidence for the Alzheimer's Association really means that regularly we have to take a look at what's going on across the globe, and across the span of all of the potential risk reduction strategies. You probably all hear in the news constantly, blueberries are so good for you. You know, red wine, which is absolutely true because it has resveratrol, antioxidants, and that's what I only drink. Is in terms of alcohol is actually also beneficial, but how beneficial? Is it curative? Probably not, right? So a lot of what we hear out there is that, oh, it's so good for you, and we have to be careful with sort of the top line news, because that's what they are. They're just basically the headlines. So what we look at is really what's happening at a population level, so that we can really be ensured that we're making the most appropriate recommendations for risk reduction strategies. But a lot of other organizations do this as well. And there are, well, certainly, I'm just going to flash this up for you here. I'm not going to read this to you, but there's just a lot out there. And a lot of this has really good science, and some we just need to build a little bit more science. Some of the other organizations that think about this, just like us, are the ones you see on the screen. And so you've probably seen these reports. And there's a lot of consistency to them. So I don't think I'm going to say anything to you that's really out of school or that you're going to be surprised about. But I'm going to go through some of the evidence. And just before I do that, I want to also share with you that, thank you. I want to also share with you that for the Alzheimer's Association, we think about how we catalog that evidence very carefully, because when we're making not only recommendations on a national scale, but on an international scale, we have to make sure that they are evidence-based and that we're honest about what you can expect from doing those things. And so we look at both cognitive decline and healthy aging, because the longer you stay healthy, the longer you stay sharp, the less this disease is going to get you at the end, or you may be able to live more time. And that's what Dan is trying to do right now, for example. But we also think about this as how long can we actually delay dementia? What can we modify about dementia? So here you see just the overview of the different levels of evidence that we looked at. I'm not going to read this slide to you, but just to provide you information on how we define these different aspects of both cognitive decline, the evidence for cognitive decline, and dementia risk as we age. So there's lots out there on so much. And this list will probably continue to grow as we discover more environmental impacts on our health that includes our brain. I'm really just going to focus on these on this left-hand side today, because they generally have the strongest level of information and support for them. So the first, of course, is education. And that's a very tricky thing to unpack. It's a very complex thing that we all understand. And traumatic brain injury as well has had a decade of ups and downs of, being very closely linked to Alzheimer's and then really being decoupled and more closely linked to dementia. So we'll go through a little bit of that. But formal education, very briefly, and you've got there's so many references, so I just picked some that were going to be the most representative here, is that years of formal education is, of course, considered to be protective. We really emphasize quality versus quantity, and that has also been published, as many of you know, especially when it comes to populations that are underrepresented and have in certain parts of our country where quality of education is lower. But the study I've cited here on the right-hand side, and you can find information about this study right here at this paper that I'm highlighting here, reviewed 88 study populations. And really the majority of them reported significant effects. And that's what's critical here. And that you see here the prevalence studies and the incidence studies, how many were non-significant in the gray and how many were significant, and more of them were significant. So there's just a lot of information out there that can point one way or another. But overall, I think we all understand that there is a significant relationship between education, broadly speaking, believed to be the result of really creating cognitive reserve. But on top of that, this particular study highlighted that this is a complex lifespan issue. There is so much that goes into education, where it's your quality and your quantity, that is associated with socioeconomic status, associated with generations of being in the United States. I'm first generation Mexican American. My parents were illegal immigrants. This is a very different thing for when I think about education and where it comes from in my family. So this is complicated. So this is just giving you this snapshot is understating things. But anyway, I only have 15 minutes. So so that's all I can tell you. Okay. So I messed this up already. Let's see. Okay. So next I'm going to talk a little bit about traumatic brain injury. As I said, traumatic brain injury is one of those that's had this sort of ups and downs on whether it's connected directly to Alzheimer's or more dementia, broadly speaking. And here's a graph that you see on the left-hand side, really from Barnes et al., who has done this type of work out of the University of California, San Francisco VA. That shows you that with no TBI, sort of, cumulative incidence of dementia is there's no doubt, but moderate to severe TBI is really what it has the strongest incidence and earlier on. And here you have it with loss of consciousnness and without loss of consciousness, etc. So this is an important thing because there's no doubt that TBIs happen in all stages of life, but certainly falls in older individuals are important to acknowledge. And there are ways to try to avoid this as much as possible. Some of it can be unavoidable, but certainly wearing helmets and, maybe not putting your kids into American football. I can't say that. I shouldn't say that in public, but, these types of things, even soccer has been shown to actually, because of the headers, can potentially increase your risk because it's repeated TBIs. So we just have to be very careful about this type of information. Primarily, we used to think that TBI really elevated amyloid beta plaques and tau tangles, which are the hallmarks and the cores of Alzheimer's, although it's a very complicated definition now, but those are the two cores still today. And today we understand that actually it really is about neuronal injury, axonal injury in particular, and one biomarker called neurofilament light really elevates, that really tells us that these TBIs cause neuronal injury. Not necessarily increases in A beta, but increases in tau, because tau is actually also a representation of neurodegeneration. So these are important to also acknowledge, and that there's a biology underlying all of these risk reduction strategies that I'm going to talk about. So, of course, everything associated with heart that I'm going to talk about here has strong evidence for cognitive decline, has moderate evidence for dementia, but more work is being done now that will help us actually, hopefully, establish the dementia part as a stronger evidence. So you guys all know all of this, so I'm not going to belabor the point, but there's a lot of strong links to vascular health, lots of factors that are associated with this. And the mechanisms you can see on the bottom here, these are just the overarching ones, but arterial stiffness, endothelial dysfunction, which is so important because of the blood-brain barrier and leakiness of it, and it causing so many issues, and especially when it comes to the blood-brain barrier in the brain. Oxidative damage, which we all know, that's why antioxidants are so important, right, to fight oxidative damage. And of course, inflammation, which is why we try to eat anti-inflammatory foods, etc. So this is all, again, things you don't know, so I'm not going to belabor the point. But Sprint Mind really created this change in how we think about things for us, certainly at the Alzheimer's Association, also for, of course, cardiovascular health. The study was stopped early, so you can see here from this graphic on the right-hand side, it's a very strong population. It was also very representative of the United States population. And the intervention, we all know, was intensive versus standard of care, which at the time was, of course, less than 140, but really pushed people down to like 121 at the end of the day here. And the cases of MCI per person, really the hazard ratio went down. For MCI, mild cognitive impairment, even if it was due to sort of all-cause, syndromic, not specifically what Dan mentioned, which was MCI due to Alzheimer's because of those biomarkers. But in this case, it's MCI all-cause. Remember that it's important because everybody that passes from cognitively healthy and unaffected has to go through that mild cognitive stage to get to dementia. So if you can avoid that, or you can delay it, that's a win. So I'm not going to belabor the rest of this, but this was just an incredible study and leading us all to think about pushing our blood pressure down to 120. So obesity, of course, is all contributes to this because how we move, how we age, how we can make sure that our heart is functioning as efficiently as possible as we age is so critical. But I'm going to highlight the Look Ahead study, which actually gave us some very interesting information. This study demonstrated that weight loss to reduce, of course, cardiovascular morbidity, mortality, and type 2 diabetes really demonstrated that weight loss had no impact on incidence of MCI or dementia. This is interesting because you think, oh, of course, weight loss should be, preventative. Probably ideally, the idea is maybe earlier in life and to try to even prevent obesity or being overweight, which is very difficult for all of us, as you just heard actually from Dr. Sherry, of like how hard it is to follow all of the recommendations we know we should be doing on a daily basis. But a lifestyle intervention that resulted in weight loss also demonstrated in this look ahead study after 10 years that they could have negative implications for cognition in individuals that were over 60. So we have to actually be very careful about what we recommend. And we all know that in older populations, when people start to lose weight, it can be actually a sign of being closer to frailty, closer to sarcopenia, and closer to death. And so I always told my parents before they passed of diabetes and heart disease that being a little chubby was actually probably protective. So let's just stay the course, but anyway, this is very complicated. So it's something that we just need to tease out. And of course, type 2 diabetes and the risk of cognitive decline has been demonstrated consistently. But one of my favorite studies is really one with metformin, and it's cited here below, because can actually treatment reduce your risk if you treat diabetes? Of course, ideally, you want to avoid diabetes because it is something that with modifiable, lifestyle interventions or just a different way of living life, you may be able to reduce your risk of and even avoid diabetes type 2. But in particular, what if you used metformin? So if you take a look at this, these are people that for global cognition and of course also executive function, which is very important for our everyday memory. If you look at people with diabetes but no metformin, they're in this dotted line for both cognition measures. But a person that had diabetes with metformin in the longer dashed lines looked more like someone who had no diabetes in terms of their decline. That's important. And my mother died of diabetes after an amputation, 6 months after an amputation above her knee. So I do very similar things to Dan because I'm trying to avoid diabetes. By my age, my mom already had type 2 diabetes. So this really keeps me motivated to keep working out 5-6 times a week, drinking my little red wine, and trying to eat my Mediterranean diet, etc. So I'm trying to do the same thing, but certainly for diabetes, and it certainly won't hurt for hopefully reducing my risk of dementia later in life. Smoking has had a lot of literature published on it, both positive and negative. Very hard to do a randomized controlled trial telling half the people to smoke and then half the people not to smoke when we all know that smoking is not good. So that's just not going to happen. But luckily, we have Framingham and other studies that have gone on for so long that tell us more information about how current smoking can increase the risk of cognitive decline and dementia. So many studies have been highlighted. I want to just share with you one in particular. It's here at the bottom, the relationship of cigarette smoking and time of quitting. Because quitting is important, and the longer you quit, the healthier you are at the end of the day. So in this graph on the side, this is the hazard ratio here. On the x-axis, it's really never having smoked, so really neutral. Quitting greater than 9 years, neutral. And quitting less than 9 years ago, a little bit higher, but current smoking certainly even higher than that. So important to note that this is modifiable. So I think that's the main message for all of us. And of course, physical activity, you heard from Dan how important that is. I try to practice it myself. I'm going to highlight this WIMS study because there's so many, and I think you'll all get these slides so you can just take a look at so many references. You can pick your favorite one. But in this study of women in particular, which of course, I was a little biased in picking this one, but with every additional 31 minutes of moderate to vigorous activity per day, you can actually reduce your risk. And so you can see here on the left in this graphic, but on the right, the underlying biology, again, because that's what there is for all of these risk reduction strategies, really demonstrates that there is increased amyloid turnover. So you got to get that stuff out of your brain, out of your body. Improvement of cardiovascular risk factors, which really helps you increase this amyloid turnover. Increased expression of neurotrophic factors, which protect your brain and your cells, your nerve cells all across your body. And decreased inflammatory responses, which we know can be protective, because inflammation is a vicious circle that once you start, is very difficult for your body to shut off, right? How many of you have experienced maybe a spinal cord injury and your doctor has to go in and give you a corticosteroid shot because you need to reduce that inflammation immediately to help your body heal. Otherwise, it just keeps going and keeps going. This is, unfortunately, this negative effect of inflammation. So very important that we all understand that physical activity has so many complex things. And sleep. Aren't we obsessed with sleep in the United States? I mean, we are obsessed with sleep. I got this Aura watch because I just want to know how I sleep. So, I mean, this ring, this is not enough. I need to have this ring to tell me how I sleep every day. And then I look at it and I'm like, man, that sucks. But, but still, now I know. But this is an example of like sleep disorders. And this is really important because this is just a very small snapshot. There are so many different types. Some sleep disorders are actually very, very serious and lead to other neurodegenerative diseases, in particular Parkinson's. But I'm just going to give you a broad example of this. Poor sleep quality is definitely associated with risk of cognitive decline and possible dementia. This is important. And we're just trying to figure out how we can ensure that we have the right studies that tell us this, because sleep is complex. But during sleep, we know from animal research and also from human sleep studies that everything that happens during the day gets consolidated in your brain cells overnight. You even have studies of college students who sleep more hours before a test, even after cramming, right? And that information is consolidated in their brain better than those who go in with like 3 hours of sleep. But an nationally representative study of older adults with 8 years of follow-up data found that 15% of older adults routinely use sleep medication, and this was associated with an increase in dementia risk. And that's study is right here. So not all sleep interventions are the same. This is one thing I think about when I think about going to ask for sleep medication with, in my PCP yearly visit. So there are, though, ongoing randomized controlled trials that will give us more information about sleep interventions. This is mostly related to CPAPs. And of course, obstructive sleep apnea is very critical. It means you're not getting enough oxygen in the brain, in addition to waking up more frequently. All of this needs to be studied so that we can see if these interventions will actually help. So very complex thing. And then lastly, there's very moderate information, which is unfortunate, about a balanced nutrition and cognitive engagement. Doesn't mean you shouldn't do it. I do it. You heard from Dan. He does it. And I think many of you follow this example as well. But balanced nutrition over time is associated with better cognition. You heard about the Mediterranean diet that Dan follows. And of course, always staying cognitively engaged is really important. We just need to know a little bit more about what that recipe could look like. What does that mean? You need to learn something every day, or is it just my Sudoku, more New York Times, crossword puzzle? I think it might be more than that. And this is, of course, all of this is related to SDOH, which you heard from Dr. Sherry very eloquently described this morning. And these are complex things that we just need to think about how we make these recommendations to the public. We certainly want to be very careful about how we convey this information to whom and where, but we do need to make sure we're conveying the right information, that it has all of the appropriate data. So there's got to be a synergistic potential for all of this. And in fact, there is a study that reported the synergy, and that was the Finnish geriatric study that reported, I think the earliest report was in 2014 at AAIC, the Alzheimer's Association's International Conference. And they really demonstrated in over 1,200 individuals at risk that a 2-year multi-domain approach did in fact improve cognition over time in this battery. It was a neuropsychological test battery, control versus intervention. Very first time we saw this in an intervention. That was very exciting. 3 years later, I approached, I did it again. I approached the Alzheimer's Association, my leadership at the time, to think about whether we could reproduce this in a larger and more diverse situation. We are not finished. They all have such a great social network. They all have access to university studies. They have great health care that's nationalized. And they're also all white. So could this, balance to some other type of population? So that's when the Alzheimer's Association in 2017 announced this U.S. pointer study, and I'm so grateful for our leadership to support this, because it's hard to get money for this type of study when you don't have as much of an ROI, and we knew we needed to do this. So this is a $100 million study. This is no breeze or walk in the park. But then we officially actually got this going in 2019, where we started recruiting the first person. We're now completed recruitment. We actually have 2,100 participants. We surpassed our recruitment levels. And we are looking forward to 2 years from now having some results from this study. I'm very excited about it. And thanks to Dr. Joanne Pike for continuing to support this, and Dr. Heather Schneider in this room, who is really a co-lead for this with Dr. Laura Baker. This is Dr. Laura Baker, Mark Espelond, of course, and other leaders here. And you can learn more about this study at alz.org/public health, because this is our effort to ensure that we are collecting an evidence-based approach to the recommendations that we know we all need. I want them myself, in terms of how I can talk to my family about what would be the best for them to do. We can talk in generalities right now. We're trying to get to specifics. So thank you very much for your time, and thank you to the CDC for this warm opportunity and welcome. It's been a fantastic partnership with you. It's clear that the Alzheimer's Association's mission and the CDC mission is very aligned, and aligned with all of you. So thank you very much for this time. Dan?
Good morning, everyone. Thank you so much for the opportunity to present to you today. My name is John Omura. I'm a medical officer on the Alzheimer's disease team here at CDC. Our Alzheimer's disease team is housed within our healthy aging branch. And before I get into my presentation, I just wanted to thank Dr. Carrillo. I know she's already, I think, stepped out, but she had to run off to catch a plane to Mexico City to attend the association's AEIC Satellite Symposium there. So we wish her safe travels, but we're so grateful that she was able to join us today and offer that wonderful insight. So I'll be presenting to you today on really thinking about the modifiable risk factors that we just heard about and moving from data to action. So I'll provide an overview of the prevalence of modifiable risk factors in the US, and then how data can really be used to help drive public health action. So just to provide a brief outline, so again, I'll recap a lot of the modifiable risk factors that we just heard about for ADRD, and then I'll provide a bit of a perspective on what we mean by a public health approach to ADRD with a specific lens on data. Really the focus of my presentation is on data and how we can use data to help inform action. Then I'll walk us through an analysis that we conducted examining the prevalence of modifiable risk factors in the US, which is a nice example of applying data from the behavioral risk factor surveillance system. And then finally, I'll close out with some examples and resources regarding data for action. So first, really, this is that recap slide. We've already heard a lot about this, but I think it's just helpful to refocus us again to think about what causes Alzheimer's disease and dementia. Of course, we know that genetics plays a strong role in determining an individual's risk of developing Alzheimer's and dementia, as does age, certainly with risk doubling approximately every 5 years after the age of 65. And those are certainly non-modifiable risk factors. But as we've heard about, there are other risk factors as well. So those common medical conditions like cardiovascular disease and in particular hypertension, as well as diabetes. And then those behavioral risk factors like smoking and not getting enough physical activity and poor nutrition. And really the interaction between multiple risk factors is extremely complex in ultimately determining an individual's risk for developing Alzheimer's disease. But as we've heard about again and again this morning already, is that what's exciting for us is that this really presents a window of opportunity. And that window of opportunity is because these risk factors we know are modifiable. We know that there are evidence-based strategies and interventions that we can implement upstream to help reduce their prevalence and then to ultimately reduce risk for developing dementia. And as well as we heard about this morning, that all of that great strengthening evidence around these modifiable risk factors resulted in this new 6th goal in the National Plan to Address Alzheimer's disease report. And this was very exciting for us, for the field as a milestone. And I think it's worth repeating the goal, which is to accelerate action to promote healthy aging and reduce risk factors for ADRD. And as we've heard previously already, that what's nice here too is the alignment between dementia risk reduction and healthy aging overall, recognizing that those two initiatives or those two goals really go hand in hand. So now shifting to a public health approach to ADRD. First, in terms of points of intervention, there are various points that public health can really intervene. And often we think about these in terms of the levels of prevention. So primary prevention really is that upstream activity trying to impact modifiable risk factors and reducing risk for ADRD. Secondary prevention is really getting at more the early detection of illness and then trying to manage illness early on to prevent worsening morbidity. And then tertiary prevention really is around the prevention and management of other comorbidities, for example, that may lead to preventable hospitalizations and decreased quality of life. It's about linking patients to care and services. And then certainly the integration, of course, is that all-important role of the caregiver. And of course, our focus for the next 2 days is really thinking about that primary prevention piece, that risk reduction piece. So I just wanted to highlight that for you here. And then another perspective we can take to a public health approach is really thinking about the tools that we have available to us in our public health toolbox. There are many tools that we have available, which is wonderful. And we often refer to those as the core functions of public health or the essential services. And one of those essential services of public health can be referred to as regarding data. And so one of the descriptions is on the slide here, which is to assess and monitor population health status, factors that influence health, and community needs and assets. And there are various types of data that are available to us. Certainly for us at CDC, one important type of data is surveillance data, and we use that a lot. And so I think it's helpful to step back when we're talking about surveillance and really think about what we mean by that term. There are various definitions of surveillance available. I find this one particularly helpful on the slide. And that definition is that surveillance is the ongoing, systematic collection, analysis, and interpretation of outcome-specific data, which can then be used for planning, implementation, and evaluation of public health practice. And I've just highlighted a few key groupings of words on the slide here that I wanted to emphasize. The first is that surveillance is the collection, analysis, and interpretation of data. And so that really speaks to the process of surveillance. So we collect data, we analyze it, and then we interpret it to identify the key findings or the key messages from those data. And then the second collection of words is around the planning, implementation, and evaluation of public health practice. So this is telling us that surveillance data should be used to plan, implement, and evaluate the public health interventions or actions that we take. So now thinking about that definition, I wanted to provide you an example of an analysis that we conducted in collaboration with our partners at the Alzheimer's Association as co-authors on this study. And I think it's a nice example of some of those steps in the definition of surveillance that I just provided around the analysis and interpretation of surveillance data, and then packaging it in a way that can be used to help inform the planning of public health strategies. And so this report was published in MMWR in 2022, and we looked at modifiable risk factors for ADRD amongst adults aged 45 and older. And so for this study, we used data from BRFSS. I'm sure many people in the room are familiar with it, but BRFSS, in case you aren't, is one of our nation's premier systems of health-related telephone surveys. It collects data from amongst U.S. residents from across all 50 states and D.C. and 3 territories, with over more than 400,000 interviews completed each year. So it's just a very robust sample size. And for BRFSS, there is a core survey or questionnaire, as well as optional modules that states can opt to administer. And our program sponsors 2 of those optional modules. One is on caregiving, and the other is on cognitive decline. And so here's just a brief explanation of that cognitive decline module. So first, it asks about whether a respondent has experienced worsening memory problems over the past year, and we use that as a definition for subjective cognitive decline, or SCD. And then for those who report having SCD, they're then asked a series of additional questions around whether they're having potential difficulties with daily living and whether they've discussed their symptoms with a healthcare professional. And this module is only conducted amongst adults age 45 and older. And you can see on the map on the slide the states that have opted to administer this module across the country and in the most recent year. And you can see we have great uptake and coverage of this module. And for that, we are extremely grateful to our state partners for that. And so the objectives of our study were to determine the prevalence of 8 potential modifiable risk factors for ADRD amongst adults 45 and older overall, and then by various select characteristics, and then to also examine the prevalence of each of those risk factors, as well as the total number of risk factors that respondents had by their cognitive decline status. And again, just to remind you, so SCD, or subjective cognitive decline, is the self-report of memory problems that have been getting worse over the past year and can be an early indicator of possible future ADRD. And so for the study, we used BRFSS data from 2019, and in that year, 31 states and DC had administered the cognitive decline module. You can see the sample size and the median response rate on the slide. On the left is the actual cognitive decline question from the survey. And then for our study, we used 8 of those modifiable risk factors, and that was really based on what data or what variables were available in BRFSS for that year. And then we also calculated, as I mentioned, the total number of risk factors that respondents had. So whether they reported having 0, 1, 2, 3, or 4 or more of those risk factors. So now here's just a few highlights of our findings. This is the prevalence of risk factors overall amongst our sample. You can see certainly that on the left there, high blood pressure was the most commonly reported modifiable risk factor, with nearly half of respondents reporting it, slightly followed by not meeting the aerobic physical activity guideline, and then in decreasing prevalence down to hearing loss and binge drinking on the right. And then I wanted to just pause here and mention, again, the data for action piece. So a major objective of our analysis was really to try and help identify opportunities and priorities for public health action, really helping public health practitioners think through, if your goal was to address ADRD and start thinking about strategies to reduce modifiable risk factors, how should they be prioritizing or tailoring their initiatives to make the greatest impact? And so one way we can do that certainly is by looking at various subpopulations. And so just to give you some examples here, these are some of those risk factors by various racial and ethnic groups. And to orient you to the slides, so all of the comparisons here are done to the white non-Hispanic population, and any asterisk indicates a statistically significant difference. So on the left here is diabetes, and you can see compared to non-Hispanic whites, that was more common in non-Hispanic blacks, American Indian, Alaska Natives, those who were multiracial or Hispanic. And then for current smoking, just as another example, current smoking, compared to non-Hispanic whites, was more common amongst non-Hispanic blacks, American Indian, Alaska Natives, those who were multiracial as well. So again, just starting to think about how, where do those risk factors stack up, and how should we really be thinking about prioritizing our efforts? And then we can do this for other various characteristics as well. So just to give you some additional examples, on the left is not meeting the aerobic physical activity guideline by sex, which was more common amongst women. And then on the right is binge drinking by more refined age groups. And so here you can see that binge drinking was more common amongst younger adults compared to older adults. And I just highlight this example specifically because I think when we're thinking about public health actions and strategies for various modifiable risk factors, it's important to consider really 2 components to that risk factor. One certainly is when in the life course does that risk factor impact the biological risk of ultimately developing dementia or Alzheimer's disease. And then the other factor is when in the life course can prevention strategies be most effective for that risk factor, to decrease that risk factor, and really ideally intervening between earlier than either of those time points. And then here is the prevalence of risk factors by that cognitive decline status. And just to orient you to this figure here, so any bar that is solid in color is amongst those with cognitive decline, and then any that have a hashed bar is amongst those without cognitive decline. And for pretty much all risk factors, except for one, you can see that the prevalence of almost all risk factors was greater amongst those with cognitive decline compared to those without, which is not really a surprising finding for us because these are established risk factors for dementia. But I did want to point out a couple of specific findings that I think are noteworthy, and that's really more in terms of the magnitude of difference between the two. So just take depression, for example, in the middle here with the green. If you look at the magnitude of difference between those with versus without cognitive decline, it's quite striking. Or even further on the right, where hearing loss was one of the less commonly reported risk factors, but again, the magnitude of difference between those two groups is quite striking. And then finally here is the proportion of respondents with the total number of risk factors that they had by cognitive decline status. So on the left is those without cognitive decline, and on the right is those with cognitive decline. And so for those without cognitive decline, you can see they were more likely to have fewer risk factors. So 0, 1, or 2 risk factors, compared to those with cognitive decline, were more likely to have more, like 2, 3, or even 4 or more risk factors. And this really speaks to the importance of developing and evaluating those multi-component strategies that are targeting multiple risk factors simultaneously. So the public health implications of this study, certainly it can help identify priorities for public health action, in particular ways or ideas to start thinking through how to tailor strategies to those populations that are at highest risk. It certainly highlights, again, that alignment between ADRD risk reduction, that primary prevention piece, and healthy aging overall. It certainly highlights the importance of early detection of both cognitive decline as well as those associated risk factors, because the earlier we can intervene on any of those, the better. And then it reminds us as well that there are many existing, we've already heard that this work is already ongoing, that there are many existing evidence-based strategies and interventions that can serve as potential strategies here. We know there are effective strategies for managing and controlling hypertension and diabetes, as well as promoting physical activity, and we can harness those. So now just shifting into that data for action piece. We of course rely so heavily on our state and local partners, and we're so grateful for their activities because in terms of public health action, that's really where the rubber hits the road. And so just some examples here of how states have been using data for action. Florida on the left here has a state health improvement plan. Within that plan, there is a priority area around ADRD with a number of goals and objectives, and they are explicitly using BRFSS's cognitive decline module data as the data source to inform those goals and objectives, which is wonderful to see. North Dakota has a great platform that pulls in data from the BRFSS module that they use to inform their activities as well. And then on the right there is Arkansas, from the Arkansas Department of Health, just noting their wonderful dissemination of data through their newsletter, not only from cognitive decline here, but I mentioned specifically also around risk factors. I underlined those pieces specifically. And you can see, for example, on the bottom that they report that 77.9% of those with memory problems have at least one other chronic health condition. So again, really speaking to that important role of comprehensive chronic disease management. For us at CDC, we are certainly busy. We have a number of activities underway all the time. One of which I wanted to highlight is our new Notice of Funding Opportunity, or NOFO, which is to fund the BOLD public health programs to address ADRD. And it funds state, local, and tribal public health organizations. And specifically for this new NOFO, I just wanted to mention a couple of things to highlight for you. One is around the structure of it, you can see on the left there the two components. But what's an important next step for us is really leaning into the implementation of public health actions as part of this NOFO, and in particular using data to inform that implementation activity. And then on the right there is collaboration, and how collaboration, particularly in regards to modifiable risk factors, is integrated into the NOFO. So one example is that the recipients will have a coalition. They will have, of course, multiple representatives on that coalition, one of which should be a public health department representative from an identified risk reduction area. So for example, from heart disease or from diabetes, and have them at the table. And then also that recipients are expected to identify and leverage opportunities with other CDC-funded public health programs that share common interests with dementia risk reduction, particularly in regards to these risk factors. And then just a number of other resources that are available to you for use. We really try to take the data and analyze it and package it in a way that is readily useful and accessible for others to use. So one is our data portal, which draws in data from BRFSS through 2021, and it's really nice and user-friendly, point and click, and the data can be stratified by a number of demographic characteristics. We also produce infographics, both from the cognitive decline module as well as from the caregiver module. And those are available at the national level as well as for any state that administered each of those modules, and then also for a variety of different subpopulations. So for example, veteran status or rural status. Places I wanted to highlight for you. Places is another resource available through CDC. It stands for the Population Level Analysis and Community Estimates of Population Health. And it provides a number of data on a number of variables, both health outcomes as well as health behaviors, but really getting more at the granular local level. So it provides data estimates at the county, place, census tract, and ZICTA level. And so on this slide are just some of the example measures that are available in places, so both in terms of health risk behaviors and health outcomes. And I've just pulled the ones that are specifically relevant to the modifiable risk factors for ADRD that we've been talking about. And so, when we think about these modifiable risk factors, and in particular, data available regarding them, it again, I think, reminds me certainly of that window of opportunity that we've been talking about, because we know, again, that there are existing evidence-based strategies, particularly through policy systems and environments, that we can use to help address many of these risk factors. So certainly, we know that there are things that we can implement to promote healthy behaviors, as well as really promoting chronic disease management, particularly in a comprehensive way. And then as we do this, by promoting, implementing, and scaling up these strategies, it can all really ultimately help reduce the risk of dementia and promote healthy aging overall. And then layered on top of all of this, which is the focus of my talk today, is really that public health data piece and thinking about how we can use public health data to drive action. Certainly there is the data analysis component, and then once we've analyzed those data, using it to plan for public health action. So for example, characterizing the population, really identifying which groups are at highest risk or at most need, and then using that to prioritize action and how to allocate resources, for example. And then using data to implement and then ultimately evaluate public health action. And so I'll just highlight quickly some existing initiatives that are already ongoing in many of these risk factor areas. So for example, in promoting physical activity and tobacco control and smoking cessation with CDC's initiatives on Active People Healthy Nation, as well as the TIPS campaign. And one specific approach for us is to potentially integrate brain health into messaging. And so on this slide are some example resources that we've developed with partners to really integrate brain health messaging into, say, nutrition messaging, and also tailoring some of those messages that to be more culturally relevant or specific to certain demographic subpopulations. And then also, again, that chronic disease management piece we've talked about, and really thinking about ways to make that more comprehensive in nature. I've highlighted here some wonderful initiatives that are already underway at CDC, like the Great Million Hearts Initiative, as well as, of course, the National Diabetes Prevention Program, as well as self-management, chronic disease programs. And so just really trying to leverage those, again, for brain health as well. And we've also, again, heard about the national strategy, but I just wanted to mention that all of these activities really align with strategies that are outlined in the national plan's new sixth goal. And so just for example, there are strategies to facilitate translation of risk reduction research into clinical practice, to accelerate public health action to address the risk factors for ADRD, one of which those actions is this summit. So you are participating in that actively right now. Expanding interventions across or through the aging network, and then addressing inequities and risk factors. And data can certainly help us with all of those. And so I will just leave you here and end with this call to action, or this charge for us all over the next 2 days, as we're thinking about, we've already heard about, we can do things around promoting healthy behaviors. We can do things around comprehensive chronic disease management. It is difficult, but it is doable. All of that can help inform and lead to dementia risk reduction, as well as promoting healthy aging overall. And from my talk, I just wanted to, again, emphasize the importance of data for action, layering over the data piece on that, thinking through how we can leverage public health data to drive public health action. Thank you. Just a plug for our program, please do stay connected with us. You can sign up for our newsletter through our website. And thank you so much for your time.
Please welcome to the stage the co-chairs of the Dementia Risk Reduction Summit, Dr. Wayne Giles and Dr. Jewel Mullen.
Good morning. So this is Wayne Giles.
And this is Jewel Mullen. I feel like I'm at the Oscars.
So we're really pleased to be here. I want to keep my opening remarks brief and personal. And the personal is about all of us, because we're public health. And it was 9 years ago that I was the incoming president for the Association of State and Territorial Health Officials when I launched my President's Challenge on healthy aging. When people said to me things like, healthy aging? There's no money in it. Or, what are you going to do about it? They're already old. And that didn't stop me, but I was really propelled by the support that I had from CDC and from people like Wayne Giles, who was here at the time, and Lisa McGuire. I'm fortunate to become part of a posse that they have kept me a part of, understanding the link between healthy aging, healthy mind, cognitive decline, and letting me be part of the group that would answer a question: dementia or Alzheimer's disease, what does public health have to do with it? And I think we just spent the past hour getting reminded what public health has to do with it. And I'm a primary care doctor, and when I go back to Texas, I intend to continue that message at the medical school where I work. So thank you all for being here. It's great to see folks who have been in this world long before I was, and another whole crop and generation of people to carry on this life mission. And I want to just say that part of what we get to do, based on what I just reflected on, is to also know the importance of this work to countering ageism and helping everyone understand that this work is really life course work that we focus a lot more on when we think about younger people, but that really pays off and benefits people over a lifetime. So thank you for being here. So an hour in, we're sort of opening the rest of the summit, and I think we have just a few slides. So look around, here's who's here in these 280 seats, more or less. As you see, most folks, everybody here is public health. You're public health even if you don't think of yourselves as public health. Public health officials, federal employees, people from academia, students. Any students want to raise their hands? I saw it's like one person do this. And then hopefully you can read down the line who else is here in terms of Alzheimer's related non-governmental organizations, other NGOs, and others. We're really thrilled to be here. I really, really appreciate Dan's words and carry them through for the next couple of days and after we go back. And let me just stop now and give the clicker to Wayne so he can tell you what else is going to happen.
Great. Thanks, Jewel. And it's always a pleasure to work with you. I can think of sort of through the year, sort of all the times I sort of would pick up the phone and say, Jewel, can you help me out here? And so it's been great to partner with you on this occasion. The other thing, I guess, as I get older, I tend to reminisce more and more. And I was thinking this morning about the, sort of going back, to the early 2000s and with Ginny Harris and Michelle Walsh, who's in the back of the room, and really thinking about sort of what could we do around Alzheimer's disease and healthy aging. And really, and Lisa McGuire was there, and Linda Anderson and others. And to see sort of what we have in the room today is really amazing. And so just want you all to sort of look around and see this. And I want to remind everyone that we're also streaming this event as well, but it's really great to see this movement. And so I'm really excited and a bit in awe about all of that. So really congratulations to all of you. And just to hear, as I was walking over, was talking with someone from a state and talking about sort of all of the exciting things happening in the state. And that to me just shows how much it's worth it. And sort of hearing Dan and sort of the impact that we all can have, I think is really inspirational for us. So the objectives of the summit really are, as you've heard this morning, about translating the science around modifiable risk factors for cognitive decline and dementia. And we really want to focus on public health actions as we do this. And to be really specific, I think as we think about sort of the rest of the next 2 days, we really want to hone in on what are those concrete actions that state, local, and tribal public health entities can undertake to have an impact. And that really is sort of what we're hoping that all of the sessions will sort of very much focus on, and that you will leave tomorrow afternoon with some concrete strategies that you all can implement. We're going to use the spectrum of prevention as we do this work. And the spectrum of prevention was developed by the Prevention Institute. It was initially focused on injury prevention, but really can be much more broader than that. And I think it's really an important emphasis around sort of how can we do our public health work that moves beyond purely education. But, one of the things that I took from Dan's presentation or his talk this morning, he said, I can't choose what happens to me, but I can choose my response. And one of the things I think we want to make sure is that people in all communities across the country have that really important opportunity to choose how they respond. And so that's part of sort of the components of the spectrum to give the opportunity for all people and all communities to do that work. The other thing that I hope you will, or we hope you will hear from the individual presentations is there are going to be some recurring themes as we look across the spectrum. And as part of that, I think it's important that you remember you don't want to just address one component of the spectrum, but as many components of the spectrum as possible. And so some of those recurring themes are going to be important as that work moves forward. So we're going to have a series of 90-minute sessions. The about the first hour or so will be you'll hear from the panelists. Each have, there'll be 4 to 5 panelists in each of the sessions. And then we want to have about 30 minutes for robust conversation and dialogue. And you'll notice in the room there are 2 mics, and we're going to ask people sort of when you have comments or questions to go to one of those 2 mics as we move forward. As I close out, I do want to mention a couple of housekeeping notes today. So first of all, bathrooms, really important, are out the back door, and you make a right and a right again, and you'll see a blue sign directing you there. We've been told, do not wander. Stay in the area, please. I don't know what'll happen if you wander, but I would encourage you not to wander. Lunch is in the foyer. All food is courtesy of the CDC Foundation. If we could thank the CDC Foundation for their support. Tables are going to be to the left and right off the foyer. I was also told no food or drink in the auditorium. However, importantly, water bottles are allowed in the auditorium. So thanks, CDC, for that policy change. Again, as I mentioned, we want lots of participation. You all have been great so far, so we'll do that. Lots of conversations. You all have also been awesome in terms of cell phones. I haven't heard any of them go off, but just want to remind all of you to mute your cell phones as well as part of that. And we will reconvene at 10:30. With the first panel. So thank you. Take a break, and there should be refreshments out back. Thank you so much.
Attention, everyone. Snacks are available, courtesy of the CDC Foundation. Please note that no food is allowed inside the auditorium. Our program will resume at 10:30.